Welcome to Module 4 of Regenerative Orthopedics for Arthritis. Today we explore advanced biologic therapies, the next frontier in signal-ohm restoration using placenta-derived and cellular products. In Module 3, you learn to harvest your patient's own regenerative signals through platelet therapies. Now we'll discover how placental and perinatal tissues provide an even more powerful arsenal of regenerative signal sums, nature's most concentrated source of healing signals. By the end of this module, you'll understand why perinatal tissues are immunologically privileged, how PDPA and PDPC orchestrate multi-pathway regeneration, and when to deploy these advanced biologics for maximum therapeutic impact. Section 1, the perinatal advantage. Let's begin with a fundamental question. Why do fetuses heal without scarring while adults form fibrotic tissue? The answer reveals why perinatal tissues hold extraordinary regenerative power. Fetal wounds heal through regeneration, not repair. No inflammatory phase, no fibrosis. Perfect tissue architecture restoration. This capacity resides in the unique signal-ohm of perinatal tissues. The placenta exists at the ultimate immunological frontier, preventing maternal rejection of a genetically foreign fetus for 9 months. This creates tissues rich in immunomodulatory and regenerative signals. Perinatal tissues contain unprecedented concentrations of regenerative molecules, over 300 growth factors, 200 plus cytokines, billions of exosomes carrying microRNAs, extracellular matrix proteins providing natural scaffolding. These tissues express minimal HLA antigens, particularly no HLA-DR, the primary trigger of immune rejection. They actively secrete HLA-G, inducing immune tolerance. This allows allogeneic use without matching or immunosuppression. Understand the regulatory landscape. These products are regulated under FDA's 361 HCTP guidelines as minimally manipulated human tissue. Processing must maintain structural integrity while ensuring safety through validated screening and sterilization. Section 2. PDPA, placenta-derived protein arrays. Placenta-derived protein array, or PDPA, represents a breakthrough in regenerative signaling. It's not a single molecule, but a symphony of coordinated signals extracted from placental tissue. PDPA production begins with healthy screened placental tissue. Gentle enzymatic digestion releases proteins while preserving structure. Sequential filtration removes cells while retaining the complete proteomic signature. Mass spectrometry reveals PDPA's remarkable complexity, transforming growth factor beta-1 and beta-2 and 3 for matrix regulation. All platelet-derived growth factor isoforms for cellular recruitment. Complete IGF family for metabolic support, bone morphogenetic protein 2 and 4 and 7 for tissue morphogenesis. The cytokine profile is predominantly anti-inflammatory. Interleukin-10 levels exceed interleukin-1 beta by 50-fold. Interleukin-4 and interleukin-13 promote M2 macrophage polarization. Interleukin-1 receptor antagonist directly blocks inflammatory signaling. PDPA contains therapeutic microRNAs in extracellular vesicles. MicroRNA 146A suppresses NF-kappa B. MicroRNA 21 promotes angiogenesis. MicroRNA 29 prevents fibrosis. MicroRNA 140 restores chondrocyte phenotype. PDPA works through simultaneous multi-pathway activation. It's like replacing a single musician with an entire orchestra. Every regenerative signal sum receives appropriate signals simultaneously. Standard PDPA dosing ranges from 0.5 to 2.0 milliliters, depending on joint size and disease severity. Protein concentration typically exceeds 15 milligrams per milliliter, 10 times higher than PRP. Section 3. PDPC, Placenta-Derived Protein Complex. Placenta-Derived Protein Complex, or PDPC, represents an enhanced formulation combining placental proteins with additional perinatal sources. PDPC integrates proteins from multiple perinatal tissues. Placental proteins provide growth factors. Amniotic membrane adds epithelial healing factors. Chorion contributes additional matrix proteins. PDPC shows enhanced anti-fibrotic activity compared to PDPA alone. Decorin levels are 3 times higher, directly inhibiting transforming growth factor beta, 3 fibrotic signaling. Increased SMAD7 prevents collagen type 1 deposition. Beyond proteins, PDPC provides essential ions for voltage regulation. Magnesium at 25 millimoles restores membrane potential. Zinc at 100 micromoles supports over 300 enzymes. Copper enables lysyl oxidase for proper collagen cross-linking. PDPC contains 10 to the 12th exosomes per milliliter. Size range 30 to 150 nanometers allows deep tissue penetration. Each exosome carries 100 plus microRNAs and 500 plus proteins. Here's the revolutionary insight. PDPC restores both molecular and bioelectric coherence. The ionic content reestablishes proper transmembrane voltage while protein signals activate regenerative pathways. Section 4. Wharton's jelly mesenchymal stem cells. Wharton's jelly, the gelatinous connective tissue protecting umbilical vessels, contains the most primitive and potent mesenchymal stem cells available. Wharton's jelly MSCs express classic markers: CD73, CD90, CD105 positive, CD34, CD45 negative. But they're unique. Longer telomeres, faster proliferation, greater differentiation capacity than adult MSCs. These MSCs work primarily through paracrine signaling, not differentiation. They're mobile pharmacies secreting precisely what surrounding tissues need. WJ-MSCs powerfully modulate immunity. They suppress T-cell proliferation through IDO and PGE2. Convert inflammatory M1 macrophages to healing M2 phenotype. Induce regulatory T-cells for sustained tolerance. The secretome adapts to environment. In inflammation, they secrete IL-10 and TSG6. In fibrotic tissue, they produce HGF and decorin. In degenerative environments, they release neurotrophic and angiogenic factors. WJ-MSCs are exosome factories, producing 100-fold more than adult MSCs. These exosomes carry regenerative cargo: microRNA 21 for angiogenesis, microRNA 146A for inflammation control, microRNA 140 for cartilage restoration. Remarkably, WJ-MSCs can transfer healthy mitochondria to damaged cells through tunneling nanotubes. This literally re-energizes failing cells, restoring their metabolic capacity. Typical dosing ranges from 10 to 50 million cells per joint. Unlike adult MSCs, WJ-MSCs maintain potency through multiple passages, allowing standardized dosing. Section 5. Amniotic membrane and fluid products. Amniotic membrane, the innermost placental layer, has been used medicinally for over a century. Modern processing preserves its remarkable regenerative properties. Processing methods affect therapeutic properties. Dehydrated membrane maintains structural proteins but loses some growth factors. Cryopreserved membrane retains viable cells and full growth factor complement. Amniotic membrane powerfully suppresses inflammation through multiple mechanisms. High levels of IL-1 receptor antagonist. Natural inhibitors of MMP2 and MMP9. Suppression of pro-inflammatory prostaglandins. The anti-scarring effects are extraordinary. Amniotic membrane suppresses myofibroblast transformation, downregulates alpha-smooth muscle actin, prevents excessive collagen deposition while promoting organized matrix formation. Natural antimicrobial protection includes beta-defensins, lactoferrin, and secretory leukocyte protease inhibitor. This reduces infection risk while avoiding antibiotic resistance. Processed amniotic fluid provides a liquid format rich in hyaluronic acid, growth factors, and cytokines. Easier injection for superficial structures, natural viscosupplement properties. Micronized amniotic membrane allows injection through small gauge needles. Particle size 50 to 200 microns. Maintains biological activity while enabling minimally invasive delivery. Section 6. Umbilical cord blood products. Umbilical cord blood contains unique regenerative elements: hematopoietic stem cells, endothelial progenitor cells, high concentrations of growth factors in a natural plasma matrix. Growth factor levels exceed adult blood by orders of magnitude. IGF-1 is 100 times higher, VEGF is 50 times higher. This reflects the rapid growth environment of fetal development. Cord blood platelets can be concentrated similar to PRP, but with superior regenerative capacity. Higher growth factor content, no senescent cell markers, enhanced proliferative signaling. Acellular cord blood products remove immunogenic cells while preserving proteins and exosomes, reduces rejection risk, maintains growth factor activity, allows off-the-shelf availability. Cord blood products synergize powerfully with other biologics, used as a carrier for cellular products, combined with PDPA for enhanced growth factor diversity, mixed with hyaluronic acid for improved residence time. Section 7. Stage-specific therapeutic algorithms. Let's integrate these advanced biologics into stage-specific treatment algorithms based on signal-ohm dysfunction. Stage 1. Early inflammatory. Low-dose PDPA, 0.5 milliliters, provides gentle signal-ohm rebalancing. The anti-inflammatory dominance counters early interleukin-1 beta elevation while preserving beneficial inflammation. PDPA in stage 1 specifically targets the interleukin-1 beta and nuclear factor kappa B signal sum. Interleukin-10 and interleukin-1 receptor antagonists suppress inflammation. Insulin-like growth factor 1 and transforming growth factor beta 1 maintain matrix. MicroRNA 146A prevents escalation. Stage 2, catabolic amplification. Combine PDPA 1.0 milliliter with WJ MSCs, 20 million cells. PDPA provides immediate signals while MSCs establish sustained paracrine signaling. The combination addresses multiple dysregulated signal sums simultaneously. PDPA neutralizes proteases. MSCs convert M1 macrophages. Together, they rescue failing chondrocytes and restore microRNA 140 expression. Stage 3, fibrotic remodeling. Deploy PDPC 1.5 milliliters with micronized amniotic membrane. The enhanced anti-fibrotic profile directly opposes TGF-beta 3S MAD158 activation. PDPC's decorin and SMAD7 block fibrotic signaling. Amniotic membrane prevents myofibroblast formation. MicroRNA 29 from both sources suppresses collagen type 1. The combination literally reverses scarring. Stage 4, end stage, maximum intervention with PDPC, 2.0 milliliters. WJ, MSCs, 50 million, and amniotic membrane. Multiple treatment cycles every 2 to 3 weeks. Combined with voltage restoration. Even end-stage joints retain dormant regenerative capacity. High-dose biologics can reactivate silenced signal sums. MSC mitochondrial transfer rescues failing cells. Success requires sustained treatment over months. Section 8. Bioelectric integration with advanced biologics. Advanced biologics require proper cellular voltage for optimal response. Depolarized cells cannot properly process growth factor signals regardless of concentration. PDPC uniquely provides both signals and voltage restoration. Magnesium restores membrane potential. Potassium reestablishes gradients. Calcium enables proper signaling cascades. Combine PMF with biologic injection for synergistic effects. Pre-treatment. 15 minutes at 8 Hz to normalize voltage. Post-treatment, daily PEMF at 15 Hz to maintain coherence during integration. WJ MSCs function optimally at negative 70 to 90 millivolts. Proper voltage enhances paracrine secretion by 60%, improves exosome production, extends cell survival in hostile environments. Day 1, microcurrent voltage assessment and normalization. Day 2, biologic injection with immediate PEMF. Days 3 to 14, daily home PEMF therapy. Week 3, repeat voltage assessment and adjustment. Section 9, combination strategies and sequencing. Timing and sequence dramatically affect outcomes. Think of it as choreographing a regenerative symphony. Always consider A2M pre-treatment in inflammatory stages. It clears molecular debris, neutralizes proteases, and creates a clean slate for regenerative signals. Provides structural support before signaling. Hyaluronic acid or amniotic membrane creates scaffolding. Follow with PDPA, PDPC for signals. Finally, add MSCs for sustained regeneration. Week 1, A2M plus hyaluronic acid, prepare environment. Week 2, PDPA, PDPC, flood with signals. Week 3, WJ MSCs, establish sustained regeneration. Week 4 onward, PMF maintenance. Knee, A2M 2 milliliters, HA 3 milliliters, PDPC 1.5 milliliters, MSCs 30 million. Hip, A2M 1.5 milliliters, HA 2 milliliters, PDPC 1 milliliters, MSCs 20 million. Shoulder, A2M 1 milliliters, HA 2 milliliters, PDPC 1 milliliters, MSCs 15 million. More isn't always better. Excessive growth factors can paradoxically impair healing. Space treatments appropriately. Allow integration between interventions. Section 10, clinical implementation and monitoring. Not every patient needs advanced biologics. Reserved for failed conservative therapy, moderate to severe disease, high proteolytic activity, or when rapid recovery is essential. Track molecular response to therapy. Baseline, interleukin-1 beta, tumor necrosis factor alpha, MMP13. Week 4, repeat inflammatory markers. Week 8, add anabolic markers, insulin-like growth factor 1, transforming growth factor beta 1, microRNA 140. MRI changes lag behind molecular improvement. T2 mapping shows early proteoglycan restoration. Contrast enhancement reflects reduced synovitis. Cartilage thickness improvement visible by 12 weeks. Set realistic timelines. Week 1 to 2, reduced inflammation and pain. Week 4 to 8, improved function and range of motion. Week 12 to 24, structural improvements on imaging. Full regeneration may take 6 to 12 months. Assess response at 8 weeks. Complete response, maintenance therapy only. Partial response, repeat biologic injection. No response, reassess diagnosis, consider surgical options. Advanced biologics require significant investment. However, compared to joint replacement, lower morbidity, preserved native tissue, potential for true regeneration, and often comparable long-term costs. Key takeaways. Let's crystallize your understanding of advanced biologic therapies. First, PDPA and PDPC provide complete signal-ohm restoration through hundreds of coordinated proteins, cytokines, and microRNAs from immunologically privileged tissue. Second, Wharton's jelly MSCs offer superior regenerative capacity through paracrine signaling, exosome production, and even mitochondrial transfer. Third, advanced biologics uniquely restore both molecular and bioelectric coherence, addressing all aspects of signal-ohm dysfunction. Fourth, success requires matching biologic selection and dosing to disease stage and dominant pathological signal-somes. Fifth, strategic combination and sequencing, prepare, signal, sustain, optimizes regenerative outcomes. Outstanding, you've mastered advanced biologic therapies. You now understand how to deploy nature's most powerful regenerative signals. Next, in Module 5, we'll explore adjunctive orthobiologics, hyaluronic acid and alpha-2 macroglobulin, the supporting players that prepare and maintain the regenerative environment. Let's assess your mastery with 5 questions on advanced biologics. Question 1. What is the primary mechanism of action for PDPA in osteoarthritis? Is it A, direct cell replacement, B, mechanical cushioning, C, multi-pathway, signal-ohm restoration, or D, simple anti-inflammation? Question 2. Wharton's jelly MSCs primarily work through which mechanism? Is it A, direct differentiation into chondrocytes, B, paracrine signaling and immunomodulation, C, mechanical support, or D, protein synthesis? Question 3. Why are perinatal tissues immunologically privileged? Is it A, they're sterile, B, they lack HLA-DR and express HLA-G, C, they're frozen, or D, they contain antibiotics? Question 4, for stage 3, fibrotic osteoarthritis, which biologic combination is most appropriate? Is it A, PRP alone, B, PDPC plus amniotic membrane, C, corticosteroids, or D, hyaluronic acid alone? Question 5, PDPC restores cellular voltage through which mechanism? Is it A, electrical stimulation, B, providing essential ions like magnesium and zinc, C, increasing blood flow, or D, reducing inflammation? Excellent work. You've completed Module 4 and gained expertise in advanced regenerative biologics. Remember, these advanced biologics represent the pinnacle of regenerative medicine. They offer your patients access to the same signals that enable Scarless fetal healing. Used strategically, they can restore even severely damaged joints to health.